The non-autoimmune bullous dermatosis. The non-autoimmune bullous dermatosis, they are with direct immunofluorescence negative. Non-autoimmune bullous dermatosis, direct immunofluorescence is negative in these diseases. Epidermolysis bullosa congenita, Haley disease, and subcorneal pustular dermatosis, and transient acantholytic dermatosis. 4 diseases: epidermolysis bullosa congenita, Haley disease, and subcorneal pustular dermatosis, and also there is the transient acantholytic dermatosis. Now we will talk about the non-autoimmune bullous dermatosis, the first disease, epidermolysis bullosa congenita. Epidermolysis bullosa congenita also has 3 types. First type is epidermal, which is epidermolysis bullosa simplex, and junctional and dermal, or dermolytic, which is the worst. Epidermal simplex, there is no nail dystrophy, no milia, no scarring, with good prognosis. It is the defect in intermediate filaments, and it occurs in early infancy, first diagnosed in early infancy. Types: autosomal dominant types, there is localized type, Weber cocaine in the hands and feet, with painful blisters that increase in hotness and sweating. This is the localized disease, Weber cocaine, hands and feet. And there is generalized disease like Kubner, Dowling-Meara, Ogna, and mottled pigmentation. The Kubner is more in the extremities than the trunk, with the palms and soles, and also the Dowling-Meara in the trunk, which is grouped blisters, herpetiform type. And when there is plectine abnormality, there is the Ogna, which is with deep ecchymosis. And also there is the mottled pigmentation, epidermolysis bullosa congenita simplex with mottled pigmentation. These are the types of epidermal or epidermolysis bullosa congenital simplex: localized type Weber cocaine in the hands and feet, generalized Kubner and Dowling-Meara or herpetiform, Ogna, and with mottled pigmentations. The junctional type, there are 2 types, Herlitz and generalized atrophic benign. And there is the dermal part, or the dermolytic type, which is the worst. There is blisters, erosions, and crustaceans, usually at birth, with scarring, teeth, pitted enamel, hair alopecia, nail dystrophy, and or absent, and there is secondary milia. The dermolytic also is dominant and recessive. Dermolytic or dystrophic is either dominant or recessive type, which is the worst. So epidermolysis bullosa congenita, clinically, there is epidermolysis bullosa simplex, junctional, and dermal. Simplex has localized type Weber cocaine of the hands and feet, generalized Kubner in the extremities more than trunk, and the Dowling-Meara or herpetiforms, and the Ogna, which is deep ecchymosis when there is plectine abnormality, and there is epidermolysis bullosa simplex with mottled pigmentation. The junctional has the Herlitz type and generalized atrophic benign type, and the dermal is the worst, with scarring, occurs at birth with scarring of teeth, hair, nail dystrophy, and secondary milia, and there is 2 types, dominant and recessive. Clinical picture, there is mechanobullous disease since birth or early in life. I will look to the teeth and nails, and there is history with similar cases, consanguinity. Family history, positive family history. Investigations by electron microscopy to detect the level of the skin cleavage, and the epidermolysis bullosa simplex is intraepidermal defect, and the junctional, the split in the lamina lucida, and in dermal there is the split in sublamina densa. So by electron microscopy there is, when the split is intradermal, it is simplex. Split is lamina lucida, junctional. Split in sublamina densa, it is dermolytic. Of course, the direct immunofluorescence is negative. And also there is immunoblotting and immunoprecipitation of the denatured protein to detect the protein, the native protein, with ELISA. And there is antenatal diagnosis with fetal skin biopsy at 18 to 20 weeks of life to show any defect in keratinocyte, tonofilaments, hemidesmosome, or anchoring filaments. And the treatment is, there's no treatment actually, but there is prevention and control of trauma with nutritional supplementation, vitamin E orally, topical antibiotics, phenytoin not effective, systemic steroids, surgical to correct disfigurement, minocycline, cyclosporin, retinoic acid, and the hope in the gene therapy. So this is the first non-autoimmune bullous dermatosis, epidermolysis bullosa congenita, epidermal, junctional, and dermal. And they are mechanobullous disease since birth or early in life, teeth and nails with positive family history consanguinity, investigation especially with electron microscope, immunoblotting, immunoprecipitation, and prenatal diagnosis. And the treatment is mainly symptomatic with the hope in the gene therapy. Here we will see the epidermolysis bullosa simplex, congenital epidermolysis bullosa simplex. To the left, there is the generalized epidermolysis bullosa type, Kubner type. There is blisters on the feet with hyperkeratosis and callus formation. And to the left, there is the generalized type, Dowling-Meara, or the herpetiformis type. You can see also milia and grouped vesicles. This is the simplex. For the junctional type, which is bad type, general epidermolysis bullosa, junctional epidermolysis bullosa, Herlitz type to the left and to the right. There is a severe extensive erosions to the left side, and to the right we see the typical periorificial involvement, and also the granulation tissue. Also there is a laryngeal involvement necessitating tracheostomy. Down here we see the junctional type, the generalized atrophic benign variant. So upper type is the Herlitz variant, and the lower is junctional generalized atrophic benign. For here we see the dermolytic or the dystrophic part type, which is the worst type. See the flaccid blisters and the sacral lesion to the left, and here we see the Hallopio-Simmons variant and the excessive full thickness erosions, ulcers, and thick scarring, mitten or mitten deformity of the fingers and nails, nail loss. And here we can see the milia also in the recessive dystrophic epidermolysis bullosa. This is also in the investigations by electron microscopy. We see the level of splitting. In simplex it is in the epidermis, epidermal part, and in the junctional it is in lamina lucida, and in the dermolytic it is in sublamina densa. The split in sublamina densa. The second thing is Hailey-Hailey disease. Hailey-Hailey or benign familial chronic pemphigus, and it is direct immunofluorescence negative. Hailey-Hailey or familial benign pemphigus, it is inherited autosomal dominant. Two-thirds of the patient have positive family history, and the age is from 15 to 25 years it started at the onset of the disease. The lesion recurrent small flaccid bulli on erythematous base, the rupture leading to erosions on erythematous base and crustaceans. Usually you don't see the blisters, we see only the erosions. And with peripheral extension and circinate pattern, healing with hyperpigmentation, especially in the site in the friction site, intertriginous, flexurals, axilla and groin, and the neck, increase and exaggerated in summer, and infection. Pruritus is common, plus and minus mucous membrane is rare, and nail there is long white streaks. The histopathology. There is suprabasal acantholysis, more extensive but less severe than pemphigus vulgaris, giving the dilapidated brick wall appearance, and few diskeratotic cells, corons, direct immunofluorescence negative, and the treatment is local steroid, antibiotic, and avoid aggravation. We will say again, it is benign chronic familial pemphigus. It is autosomal dominant disease, blisters leading at the friction site in the intertriginous area neck, increased by heat in summer and infection. There is bully, that rupture leading to erosions and crustaceans. Histopathology. There is dilapidated brick wall appearance. There is suprabasal primary acantholysis, more extensive but less severe than pemphigus vulgaris, and there is few dyskeratotic cells or corons. There is differential diagnosis with the Darriere disease, whereas there is suprabasal lacunae, but the dyskeratosis is more. As we said, there is long white nail streaks, and the treatment local steroids, antibiotics, tetracycline and erythromycin, avoid aggravation factors like heat and trauma, and infection, bacterial candidal infection. Indirect immunofluorescence negative, and this is the differential diagnosis with the Darriere disease clinically and histopathologically. Clinical, there is dirty yellowish greasy papules, warty papules in the seborrheic sites like behind the ears, neck, and upper chest. And for the nails, there is alternate white and red streaks, and also there is a notch in the nails. And here the suprabasal lacunae with dyskeratosis, corons, and grains. It's basically as Haley disease, but the dyskeratosis is more. What's the meaning of dyskeratosis? It is abnormal premature keratinization, abnormal and premature keratinization of individual cells. As we can see, there is corons, which is deep, and grains, which is superficial, and there is also the differences between Haley and Darriere disease with the acantholysis and with the dyskeratosis. The dyskeratosis is more in Darriere disease, and acantholysis is more extensive in Haley disease. This is the differential diagnosis of Haley and Darriere disease. Clinically, we can see here this familial benign pemphigus or Haley disease, the site of predilection, intertriginous area, especially in the axilla. We see here the clinical picture, and also here we see also another picture of Haley disease, erosions and erythema, tiny fissured lesions also in the scrotum, and we see here also the lesions of the Haley disease, erosions on erythematous base on the axilla of the patient. Here we can see the histopathology of the Haley disease, familial benign pemphigus. There is suprabasal bully, primary acantholysis to make dilapidated brick wall appearance, and we see few dyskeratotic cells, corons. The third disease is subcorneal pustular dermatosis. Subcorneal pustular dermatosis, it is a chronic, benign, relapsing pustular eruption that affects the trunk and spares the face and mucous membrane, age 40 to 50 years in females, 4 to male 1, and characteristic histologically with subcorneal bully that contain polymorph nuclear leukocytes. So it is a chronic, benign, relapsing pustular eruption which affects the trunk and spares face and mucous membrane, and characteristically with subcorneal bully that contain polymorph nuclear leukocytes. Clinical picture, there is sterile pus. It is pruritic and annular usually, or serpiginous pattern in the trunk, groin, and axilla, but never the face and mucous membrane. And there is fluid level, hypopyon level in some lesions where pus accumulate in the lower 1/3 or 1/2 of the large pustule. Healing occurs with superficial rust and later brown pigmentation. The histopathology, there is subcorneal polymorph nuclear leukocytes, and here we have a differential of subcorneal pustules that like pustular psoriasis, there is spongiform pustules, the subcorneal pustular dermatosis as we have here, and there is immunoglobulin A pemphigus, the subcorneal pustular dermatosis type. Here we have direct immunofluorescence positive. The pemphigus foliaceus, we have eosinophils, and immunoglobulin G positive, and impetigo we can differentiate it with swab and culture positive for strep and staph, and candidiasis with satellite lesions and budding yeasts, and miliaria there is new or few, and there is tiny small closely set hot humid climate it happens. This is the differential diagnosis: posterior dermatosis, subcorneal posterior psoriasis, immunoglobulin A pemphigus, pemphigus foliaceus, impetigo, candidiasis, and miliaria. The treatment of the subcorneal posterior dermatosis is dapsone, 50 to 150 milligram per day, and sulfapyridine. Some believe that it's a variant of posterior psoriasis, but spongiform pustules only occur in posterior psoriasis. So this is the subcorneal posterior dermatosis clinically and histopathologically and treatment. This is the characteristic clinical picture. As we can see, subcorneal posterior dermatosis, the typical distribution, especially the groins and abdomen to the left, and there is hyperpigmented macules after healing of the lesions. And we can see here also with close-up there is we can see the lesions of different development stages, and there is also the hypopyon formation, which the pus accumulates in the lower half of a large pustule. We can see here also the subcorneal posterior dermatosis histopathologically, with subcorneal pustule filled with polymorph nuclear leukocytes. Underlying epidermal layers contain slight edema and some migrating leukocytes, and there is mild inflammatory infiltrate around blood vessels. So there is subcorneal pustule with polymorph nuclear leukocytes, and the treatment here is obvious, the dapsone. Transient acantholytic dermatosis or Grover's disease. Age more than 40 years, especially in males 3 to 1, males to female. Exacerbation factor: sunlight, heat and fever, especially sweating and ionizing radiation. And clinical picture: there is pruritic discrete papules or papulovesicles in the trunk, around the clavicle, anterior aspect of the chest, lower rib cage, upper back and lumbar area. It is transient for weeks or months. The pathogenesis is unknown. The acantholysis may be due to Demodex folliculorum infection, or to Malassezia furfur infection, or thermal injury leading to release of enzymes and acantholysis, or small molecules sweep into the sweat duct into the epithelium leading to acantholysis. Clinical picture: this is the clinical picture we said, and the histopathology: it is either pemphigus-like or Derriere-like, and sometimes it's associated with steatotic eczema or skin cancer, atopic dermatitis, allergic and contact dermatitis. We can electron microscopy. There is some disc keratosis and direct immunofluorescence negative. The treatment is avoiding exacerbation factor, potent topical steroids, oral retinoids, dapsone, grains, radiation, emollients, methotrexate, 25 to 50 milligram per week, effective in resistant cases. So it is pruritic discrete papules or papulovesicles in the trunk. It's transient and histologically either pemphigus-like or Derriere-like. Is it a separate entity? And direct immunofluorescence, of course, negative, and the treatment is avoiding the exacerbation, topical steroids, dapsone, methotrexate, and emollients. We will give a note now on the acantholysis. The acantholysis definition: it is loss of cohesion between epidermal cells. It is either primary or secondary. Primary means on unaltered cells due to dissolution of intercellular cement substance. And secondary, it is altered or damaged cells. The secondary examples are either altered or damaged cells secondary to infection, as herpes simplex or impetigo, herpes usually with lymphocytes, and impetigo, and pre-malignant or malignant conditions like solar keratosis and like squamous cell carcinoma, especially the adenoid type. Also, the secondary includes subcorneal posterior dermatosis. This is the secondary acantholysis. What about primary acantholysis with the unaltered cells? It occurs in pemphigus, Hailey-Hailey disease, Darriere disease, transient acantholytic dermatosis, warty disc keratoma, and incident and focal acantholytic disc keratosis. Acantholysis is loss of cohesion between epidermal cells. It is either primary among unaltered cells, only dissolution of intercellular cement substance, or among altered or damaged cells, which is the secondary type due to infection, herpes impetigo, pre-malignant and malignant like solar keratosis, squamous cell carcinoma, adenoid type, and subcorneal posterior dermatosis. The primary like pemphigus and Hailey-Hailey Darriere disease, transient acantholytic dermatosis, warty disc keratoma, incidental focal acantholytic disc keratosis. And that ends the intraepidermal bully.